Here we have a slide of blood that's circulating from the heart and out to the lungs. Air is coming in. Our cartoonish drawing is showing us two balloons that are getting air from outside, going down to the smaller air sacs or smaller air balloon there, getting this exchange. Blood then circulates out from the heart, indicated by the black arrows, and then returns back into the left atrium, indicated by the two green arrows. Now, there may be an obstruction in blood flow returning back to the left atrium, and this would be what was called a pulmonary embolism. In other cases, we may also have decreased backup flow or less ventricular dysfunction, causing blood flow to back up, and this may cause pulmonary edema. Air is still getting in, but is unable to get down to the area in this diagram where all of those green lines at the base, and so we have this bilateral accumulation of fluid. And when we listen to those lung fields, usually at the base, we would hear ralls or crackles. As this fills up, bilaterally we'll hear these ralls and crackles move up through the thoracic cage, and in these lung fields we can imagine that is going upwards. And so at this point we're looking at a base by basilar crackles. It can go up maybe a quarter way of the chest cage. We can maybe look at a halfway up and maybe even a third way up. So when we are trying to gauge how far up these ralls or crackles go, as we listen to the right and left sides of the chest, both anterior and posterior aspects, we want to gauge how far up we're hearing this type of lung sound. Again, in pulmonary edema, it is because that the heart is either weaker or that it had failed because of a heart attack, and then the valves now are incompetent, and we have backward flow. And we have decreased volume returning back from the pulmonary vasculature, causing this overspilling around the alveoli, causing the edema to develop. If it is an extremist, we may even see them having more than trouble breathing, but then coughing up what's called pink frothy sputum. Pink frothy sputum. This will require us to then force air down and try to aerate and get the air through this blockage as that fluid builds up. And we want to try to cross over that so that it can get into the alveoli and cross over to the capillary matrix where the red blood cell is sitting and waiting for that blood, that oxygen and that red blood cell to then exchange. Now, we mentioned that there are many different delivery devices for positive pressure and forced ventilations in. Continuous positive airway pressure, which is a CPAP machine. There's also a bi-level positive pressure, or BiPAP. We can also take over their airway and place in a breathing tube, an endotracheal tube, through a type of rapid sequence intubation or paralytic, and then we would then ventilate and cause higher airway pressures to try to recruit the lungs and open that lungs up and to get that oxygen exchange in that capillary alveolar matrix. In this cartoon drawing, we are looking more at a pneumothorax. We have the deflation of one lung, and as it deflates, it pulls away from the thoracic cage. We know that we have a lining, a visceral and parietal lining. This pleural lining slips off of the lining of the wall and off of the lung, causing that potential space indicated by those arrows. As air continues to come in through the trachea and down the right and left mainstem bronchus, air will then displace itself and leak out from the deflated lung tissue and fill up and collect in the areas where the arrow is showing, causing an increased interthoracic pressure. So as they keep breathing in, that space fills up, it fills up, it fills up, it fills up, and it causes this pressure to push towards the good lung. This may cause a compression of the heart or myocardium, kinking of the aorta, and compression of the trachea, shifting it towards the unaffected side. As a result of the compression of the myocardium or heart and the kinking of the aorta, we'll have decreased cardiac output, as the heart's no longer to then eject volume and to gain any volume in return during relaxation. Identifying this would indicate that over the deflated lung area, we would hear an absent or diminished lung sounds. Some of our upper airway obstructions, this could just be a foreign body airway obstruction where this person just swallows something. As we can tell from this cartoonish drawing, the mouth and air comes into this passageway and it shares a space before it then bisects into the esophagus and trachea. So this hypopharynx area is where an obstruction can occur, and it can include both the esophagus and the trachea. It can happen higher up, in fact. And so what we're trying to do is clear this by using the Heimlich maneuver, or in pediatrics for our infants, back close and chest thrust. This might cause inadequate oxygen exchange, so the person cannot speak. There is no air movement from the chest out through the nose and mouth, and they're turning cyanotic. When we look at our patients, we need to determine the degree of respiratory distress. Now, there are many different indicators, and you'll have to determine how to decide what's special to you to identify what's somebody who's normal breathing pattern to extremely abnormal breathing pattern. And so we tend to describe this as either no respiratory distress, a mild respiratory distress, moderate respiratory distress, and then severe. And then respiratory arrest is its own category where there's no exchange going on and the person is probably unresponsive. So this spectrum is based on a provider. So you, as the provider, you need to come up with an idea. And I've just listed some of these this would be for just the adult. All right. So a normal respiratory rate is about 12 to 20. The person has no respiratory distress because you can't see the person breathing. We use the pulse oximeter. It's way above 95. This person can move around. He's standing erect. He can lay flat, supine. He's oriented. There's no accessory muscle use. He's able to speak in complete sentences. Lung sounds are clear. Now, as we move through this spectrum, somebody with a mild respiratory distress may have an elevated or lowered respiratory rate. We may actually see this person starting to breathe now, using muscles to breathe. The pulse oximeter may be less than 94, and the person might want to sit upright or lean forward. As we move to moderate respiratory distress, pulse ox may be decreasing, respiratory rate definitely bumped up, and the person is having a more upright, erect position. Moving from moderate to severe, the person may end up now tripoding, unable to maintain saturations above 94 and respiratory rates way above 20. Using accessory muscle use, they may be now confused. They can only speak in one-word sentences or utter a little something, and their lung sounds are more advantageous. You would hear either wheezes, ralls, rhonchi, absent or diminished lung sounds, depending on the medical emergency. As we move from moderate to severe, now to severe to respiratory arrest, this is where the person is no longer to maintain their mental status. They're not tracking us, they're not following us, their eyes are closed. Their accessory muscle use is immense, but they're unable to sit upright already. They aren't able to speak much at all, and they're not moving air at all. So their exchange and the lung sounds are very diminished because they're not able to exchange air all the way towards the base of the lung field. So again, this takes some time. I would need you to kind of write this out so that you can see what you would be looking for when we start to examine and interview our patients. You want to be able to determine that the person has some degree of distress, so that you don't ask them certain questions like, are you having trouble breathing? Definitely on the person that has a moderate to severe or severe respiratory distress, we need to know that we need to act quicker and respond quicker as far as delivering some type of treatment and correcting this airway problem and fix this breathing issue. And then somebody that's in severe or trending towards arrest or is in respiratory arrest, we need to now fix and correct those life threats by providing a patent airway, providing ventilation, and then giving oxygen.